Welcome back, everyone. We're going to talk about non-small cell lung cancer as we continue our morning looking at new research advances. I'm really happy to have Greg and Heather joining me here to try to go through the data that we have and what we expect for the future. So we'll be talking about non-small cell lung cancer. If everybody could have a seat, we're ready to get started. And interestingly, it appears that the pelican plot idea has not made it to lung cancer because they never heard about the pelican plot, so they like the idea.
Yeah.
So Heather, I want you to look at that. One of the things that we're doing is kind of reflecting back on some of the cases that have been presented at our webinars and other webinar events by docs in practice. And of course, the Florida Cancer Specialists have presented literally hundreds of cases both in these meetings as well as others. But this is my favorite pelican case of in terms of lung cancer, a patient of Dr. Pelez. And notice the date. You know, when you think about the future of oncology, and really, are we going to maybe in the future really see better outcomes with this disease? Is the pelican really going to open its mouth? I think about this 80-year-old woman who was already receiving azacitidine venetoclax for AML, which used to be patients were going to palliative care if they were 80 years old. AML. She was in remission when she was diagnosed with lung cancer, but it turned out she had a PD-1 level of 95%. So she's coming into Dr. Pelez's office, getting her azacitidine venetoclax and then her pembrolizumab, doing fine. He gets called by the sheriff's office one night that she passed away in her sleep. So on the other hand, she presumably lived a normal life in spite of having two diseases that would have been devastating. Do you think this is what we're going to be doing 10 years from now, Heather?
Well, I think that there certainly is a minority of patients with non-small cell lung cancer, especially when there's high PD-L1, where we can get these phenomenal responses and they can do well. Actually, a patient came in to see me last week, newly diagnosed, and we got her PD-L1 level back and it was 95%. She's actually earlier stage. We think it's a little complicated, some questionable things on the scan, but it was a really happy conversation because she came to see me thinking, this is it, I'm in my early 70s, my life is over, no more travel, no more all the things she likes to do. The problem is it's not everybody, and so I think that's where the future lies, is how do we get more of the tumors responsive to immune therapy, because that's really where you can get these long-term benefits.
And of course, the other big tool that we have in oncology, and particularly in lung cancer, has been targeted therapy. Greg is about to review some of the more recent developments. You can't even cover targeted therapy in a couple hours for lung cancer nowadays, so we're just picking out some of the highlights. But again, Greg, as you see the future over the next 5, 10, 15 years, any thoughts where targeted therapy? Right now, we don't see the kind of sort of longer term response that you see with immunotherapy. Do you think that that's in the future?
I think it is in the future, but maybe a little bit different picture. I think with immunotherapy, we give drugs for a limited duration and hopefully get a cure where patients are treated and they're done with therapy altogether. I don't see us being able to do that with targeted therapy. It's going to be a continuous therapy, but hopefully with better drugs or drug combinations, we're able to get more durable responses and more likely responses.
Well, also, we talk about functional cures. If you think about CML, this story of a patient dying in their sleep, that's kind of what we hope happens with CML patients, that they die of something else, because unfortunately we can't avoid that completely. But let's talk about, and we'll ask you, Greg, to talk about some of the many highlights that we've seen recently in terms of targeted therapy.
This is the pie chart that I use to describe patients with lung cancer nowadays. And this is, you've seen a lot of pie charts over the years, and usually they have all sorts of what I'll call aspirational targets, things that are a little slice of the pie that you've never seen before and you're never going to see. And there maybe is a drug, there's maybe not a drug. But this is a pie chart that has targets that have FDA-approved drugs, and it's a pretty exciting time, I gotta admit. Now I'm gonna start talking about EGFR mutant lung cancer, and I think we all think of EGFR, we think of exon 19 deletions and L858Rs, the common sensitizing mutation, which you see on this pie chart representing 18% of patients. But there's about 1% of people with lung cancer who have something called an EGFR exon 20 insertion. And I'm gonna talk first about those patients. Now, today, As I talk, we have 2 FDA-approved drugs for the targeting of patients with EGFR exon 20 insertion. On the left is mobocertinib, which is a tyrosine kinase inhibitor, an oral agent. On the right is amivantamab, which is an EGFR MET bispecific antibody, so an infusion versus an oral agent. I'm going to take you through the data on the first one, mobocertinib first, and then there'll be a twist in the plot. So this is the waterfall plot for mobocertinib in patients with EGFR exon 20 insertion non-small cell lung cancer. All these patients had had prior platinum-based chemotherapy, so this is second-line therapy for patients with EGFR exon 20 insertion. And you see a decent response rate of around 24% in the what's called the exclaimed cohort, and overall 32% in patients who've had prior platinum-based chemotherapy. So a reasonable response rate and a waterfall plot that shows the vast majority of patients having a good response. Always important to talk about toxicities, and if you look at this toxicity table, which I won't dwell on, the primary toxicities are rash, diarrhea, paronychia, kind of classic EGFR-related toxicities. Now, I'm going to skip ahead a couple slides to show you the schema of a trial. So this trial here was led to so that based on the data I just showed you, there was an accelerated approval of mobocertinib. And so they said, we need to get full approval, we need to do a randomized trial. And this is the trial they ran. They took frontline patients with EGFR exon 20 insertion and randomized them either chemo or mobocertinib. And so this is a little bit of a different population than the prior study. Now, as of July 31st, we heard a press release that said that mobocertinib failed to improve the progression-free survival for these patients compared to platinum-based first-line chemotherapy. And so, going back a couple slides, as a consequence, just this week, we learned that the manufacturer of mobocertinib announced that they were withdrawing mobocertinib from the approval process and likely will be off the market soon. So this whole talk on EGFR exon 20 insertion has now actually boiled down to just one available agent, and that one available agent is amivantamab.
Could I just interrupt for a second? I was kind of confused by this. Why would they pull it off the market? You could still use it second line, right? It works. Good waterfall plot.
Yeah, I'm with you, Neil. I think this is it's a disappointing move because it's essentially what it means is that the company did the wrong randomized trial. If they would have compared it to docetaxel in the second-line setting, I think they probably could have beat it, and it would have been a good drug to have. But they wanted to move it into the front line, as we have with most TKIs. But it shows
without randomized trials, because we had one trial that worked, the IPS trial with EGFR, but they did this study.
Yeah, yeah, and I think it shows us that some drugs can beat frontline platinum-based chemotherapy, but drugs with response rates in the 30% range might not be able to beat platinum-based chemotherapy.
Interesting. Please continue.
So we are left now with amivantamab, which is, as I mentioned before, an EGFR MET bispecific antibody. And so this is the waterfall plot for that group of patients who, again, prior platinum-based chemotherapy for the most part, all patients got amivantamab. This is the waterfall plot showing a 40% response rate. So very similar waterfall, very similar response rate, but nonetheless an active agent. The toxicity profile for amivantamab is slightly different. You see in this busy table on the left, the toxicities that are most common are those for all EGFR inhibitors, things like rash and paronychia. There is a unique wrinkle here, though, that with amivantamab, patients have infusion-related reactions. Typically, it's a grade 2. Typically, it only happens with the first dose of drug. It's not a great way to prevent it, so we generally just give it, tolerate it, and I'll tell you as sort of a practical thing that when patients have this infusion-related reaction, you stop the drug, tell them to go home, come back the next day, and it doesn't happen again. So it's generally a manageable thing. So amivantamab has that same commitment to do a randomized trial, and this is the randomized trial that they've chosen to do. And they are moving it into the frontline setting, but this study compares carboplatin pemetrexed to carboplatin pemetrexed plus amivantamab. So rather than replace platinum-based chemotherapy in the first line, they've elected to try to add on to platinum-based chemotherapy. And we did see a press release here that this was a positive trial, and we're going to see results of this presented at ESMO in a couple weeks.
Could I just clarify one thing, though, Greg? And incidentally, when I interrupt people, we stop their timer, so, they still have their talk. But just because, sometimes you bring things up, and before you forget, it may be better to get it out. We talk a lot about bispecifics, particularly in hematologic cancers. We're going to talk later on this morning about bispecifics and lymphoma that are, in my mind, like immune bispecific. The other part of the bispecific goes after the immune system. But both of them, it's not that this type of agent, both of these are attacking the tumor cell.
Right. This is not that. This is, the idea here is to take two targets that I think might be important in the tumor. And so you hear sometimes about MET amplification as a resistance mechanism. So it's designed to hit both targets.
It's important to keep in mind because we're going to be seeing some data with this drug in the next few weeks. I don't know what it means, but it looks pretty interesting.
Yeah, for sure. So we'll move next to that 18%, the much more common group of patients with EGFR mutant lung cancer with the EGFR exon 19 deletion or EGFR LE58R. And for a long time, osimertinib has been the standard in that setting. And until we've recently seen data that was presented at the World Lung Meeting in Singapore just a few weeks ago. And this is the FLAURA2 trial. This is a schema showing what the trial design was. Essentially, it took patients with newly diagnosed EGFR mutant lung cancer and randomized them to either osimertinib, the standard of care, or osimertinib plus chemotherapy with carboplatin pemetrexed, including maintenance pemetrexed. So it's really just a pill or pill plus some chemo. This is the progression-free survival endpoint of the trial, the primary endpoint of the trial. You see a pretty clear improvement in progression-free survival. For the osimertinib monotherapy in blue, the median progression-free survival is about 17 months, kind of what we expect for a single-agent TKI in this setting. And osimertinib plus chemotherapy led to a median progression-free survival of almost 26 months. So a clear improvement, but of course it comes with the cost of visits every 3 weeks to the office and the chemotherapy side effects. So it's something we have to weigh. And we always have to put that into the context of what would happen if we gave the pill first and then we switched to chemotherapy second. And that's kind of what you see here, which is what looks at the overall survival, sort of sequential treatment. And you see there wasn't a difference in overall survival, whether they started with the pill or started with the pill and chemotherapy. So I think my take home from this is that I'm not ready to change to give this as my standard first-line therapy for patients. I'm still probably going to stick with the EGFR TKI for most patients. There might be an opportunity to kind of tweak things in a patient who's very symptomatic or for some reason I really need to get a better response earlier.
So just to pick up on that before you continue, I'm curious about what Heather's take is on this. Initially you would think that you'd be thinking about really sick patients. Do you get a little bit of an extra early bump? Is that what you're going to be thinking of? I think I've heard people talk about brain met patients thinking about this. Are there situations right now where now this is something you're going to think about?
So, from the big picture, it's that concurrent versus sequential, right? You give it all together, you do one and then the other, and I think Greg and I have similar interpretations. You're not really changing overall survival. The subsets, and I think it's hard to go into every detail, but the patients with L858R, the patients with brain metastases, those are the ones seeming to have a little bit more benefit. So in that group, I will talk with them. I'm having trouble understanding the brain mets part because osimertinib's better in the brain than most of our chemo.
Right.
And one outlier result doesn't always equal truth. So, but it is something I'm talking about. This got a lot of press. Many of my patients in California have heard about this and are asking me about it, but it's not something I'm going to be doing with most people, but we'll talk about it.
And Greg, we've had this paradigm that really started in lung, and you see other tumors, breast doing this also, of holding off on radiation therapy in some situations. For example, EGFR, just using osimertinib, but again, are you going to think about now chemo on top of that?
Yeah, I think it's definitely something to think about, but I'm not routinely going to do it. And even patients with brain metastases, I think osimertinib works extraordinarily well in that context, and so I'm going to move forward with just that.
And of course, as you alluded to when we got started, the real problem here is even though these are great drugs, at some point they stop working, and that's where this next data comes in. Yeah, so a resistance to EGFR TKIs is the frustrating thing for us in the clinic. We give a pill, works great for a couple years, and then the patient's in front of us, and we told them they didn't need chemo, and now they're fearing chemotherapy, and so it's always a tough conversation. So how do we approach this? One of the drugs that's currently being developed, currently under study, is a drug called patritumab deruxtecan. And so essentially this is an antibody drug
conjugate with a target of HER3. Now, HER3 is one of those EGFR receptor family proteins that's on the surface. We don't really think too much about it, but it turns out to be important in resistance to EGFR tyrosine kinase inhibitors. And this drug has been studied in patients who have osimertinib resistance. This is the very busy waterfall plot recently published in the JCO, and what you see here is a response rate of 29% in a very large group of patients, 225 patients treated. But this is single-agent patritumab after osimertinib, suggesting a very good response rate and something that we're going to want to look at going forward. Now, another approach we can take is using that drug I mentioned to you earlier, amivantamab, and adding a drug to it called lazertinib. Lazertinib is very similar to osimertinib. It's another third-generation EGFR TKI. Could we use these two drugs together, sort of a dual inhibition of EGFR type approach? And people have started looking at that, and this is an example of a trial of that. So this trial took patients who had had osimertinib, who'd progressed, and then they gave them amivantamab and lazertinib after progression on osimertinib. And this is presented at ASCO this year. You see the response rate was 30%. So kind of like that patritumab deruxtecan I just told you about. So it's an interesting opportunity to see this is a potentially active combination after osimertinib. So it's currently being developed a little bit further, and this is another trial we're going to see the results of in a couple weeks. This is, I believe this one's called Mariposa 2. So this is a trial where they took patients with metastatic EGFR mutant lung cancer who'd had osimertinib and progressed, and then they're randomized to, in the blue there, that's the standard, carboplatin pemetrexed, or two other combinations. One is carboplatin pemetrexed plus amivantamab, and the third option was carboplatin pemetrexed plus amivantamab and lazertinib, kind of throwing the kitchen sink of EGFR all together. The primary endpoint of this trial is progression-free survival. We're told in the press release that both arms, both of the yellow boxes here, are better than the blue box. So we'll look forward to seeing how much better. If it's going to work after osimertinib, maybe we could do this instead of osimertinib. And so this is the Mariposa 1 trial, which looked at upfront use of combination of amivantamab and lazertinib. And so in the green box here is that amivantamab-lazertinib combo, then osimertinib is the control arm, and then lazertinib is another arm here. So just the two different TKIs, which I think we can all presume will be similar, or that green box, which is the combination of amivantamab and lazertinib. So again, we'll see the results of this at ESMO in a couple weeks. Reports are that the green box, amivantamab lazertinib, is better than osimertinib. I think the big questions that we'll all have are things like overall survival, things like how much toxicity there was with the combination of two EGFR targeting agents over, which is probably 2 years for these drugs in this setting. So it'll be a lot to look at.
So before you go on, this is the one that I'm wondering about, Heather. So is it possible that we're going to replace osimertinib first line? I mean, it depends on the data. Mm-hmm. We just have a positive press release. If the data is supportive, this can be a big quality of life difference, I would think. Any thoughts?
I think it's really about that quality of life question. I mean, we don't know if lazertinib is different than osimertinib. I think in practice, we've been assuming it's not going to be that different. If we add this other drug, amivantamab, it's weekly for the first month. It's every 2 weekly. There's a significant increase in rash. It's going to be the same questions that we have with FLAURA2. If you reduce lifestyle, quality of life early, and that leads to a longer time of you going through those toxicities, but then in the end, overall survival is the same. Are we going to change practice or not? Either the amivantamab, lazertinib, or sometimes off-label amivantamab, osimertinib, that has pretty reasonable efficacy after single-agent osimertinib. And so again, it gets to everything together versus sequentially. And it could be that concurrently is going to be better. We might be delaying some of the MET resistance, which is a pretty common resistance pathway. And if you start with MET inhibition, you might delay that, and that could have some impact. So I'm not necessarily as skeptical going in as I sometimes am, but they're going to have to show us that this isn't just, that this has to be truly better than if you give the osimertinib or lazertinib alone by itself and then the combination, that you get further down the road than if you just give them all together. So we'll see.
Yeah, I feel like we're covering so much data in this module. It's better to just take it and talk about it each time and come back and try to remember it.
And then we've got ESMO next in 2 weeks.
You got
so it's
ESMO,
gonna be
everything's going to change in 2 weeks, but let's keep going.
All right. So this is great data in the metastatic setting. How do we move it into the curative early stage setting? And of course, this is all built off of the data from AD-AURA, which is this randomized trial of patients with resected stage 1B to 3A non-small cell lung cancer who got chemotherapy if the doc wanted to or not if the doctor didn't want to, and patients were randomized to either placebo or osimertinib for 3 years. And what we've been talking about this trial for a little while based on its disease-free survival improvement, but this year we saw data on the overall survival improvement. And you see here a clear improvement in overall survival for patients who got osimertinib versus those who got placebo.
Just to point out, though, we did a poll of investigators, and I said, were you surprised when you saw the mortality? Hazard rate and mortality on 0.5. And there were people saying, well, we don't think there's going to be a survival benefit when the data first came out. And we polled the investigators, we were expecting that. Were you expecting to have a 50% reduction in mortality?
I will admit that I was not expecting a hazard ratio of 0.5. I thought there would be something like 0.7, 0.8, and we'd kind of talk, and we'd say, 3 years, blah, 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 but I'm impressed.
I'm just hoping we see more of that, because that was a pleasant surprise, and we always think progression-free survival, who knows what's going to happen, you can retreat. This comes up in many cancers, and just conceptually, when I saw that hazard rate, I was like, whoa, that's interesting.
Now, one thing that people start to ask is, hey, do these patients need chemotherapy? And this is one of the figures that was shown in the initial presentation, and it was all very exciting. It said, if you look on the left, patients who got chemo, patients on the right who didn't get chemo, and gee whiz, they're about the same. If you look at their 5-year overall survival numbers, maybe they don't need it. But you got to remember that this is a mix of stages, and the patients who didn't get chemotherapy had a lot of 1Bs, so they're going to have a better outcome. And so really when you dig into it, if you go to the supplementary data and you look just at patients with stage 2, 3, those are the ones who we would give chemo to for the most part. And I broke it down just looking at 5-year overall survival. If you got no chemo and placebo, your 5-year overall survival was 66%. If you got chemo but no osimertinib, 5-year overall survival is 75%. No chemo but some osimertinib, 5-year overall survival 80%. And the best outcome went to those patients who got chemo and 3 years of osimertinib with a 5-year overall survival of 87%. So to me, the take-home message is we still need chemo for these patients. So we'll move through a quick glance at a handful of other targets that you see pretty uncommonly but are nonetheless important to think about. So trastuzumab deruxtecan has been evaluated in patients with HER2 mutated non-small cell lung cancer, and you see the data here, response rate of 50%. So when you find HER2 mutated non-small cell lung cancer in your clinic, there's an FDA-approved agent for that context. Similarly, MET exon 14, pretty uncommon event, but nonetheless a very important target. We see that capmatinib has significant efficacy both as a first-line and second-line agent. And similarly for MET exon 14 is tepotinib, another MET exon 14 inhibitor. Good response rate in the first line of 44% and the second line of 48%. Notably in this trial, they enrolled patients on liquid biopsy or tissue biopsy, and they found similar response rates, whichever way you found it.
Getting back to the issue of first-line therapy that we were just talking about with mobocertinib, in what line therapy do you use targeted treatment? You mentioned these two drugs, and any preference for one versus the other?
Yeah, I typically use MET-targeted therapy as a first-line agent for patients with MET exon 14. I don't have a strong preference between capmatinib and tepotinib. I think they're both similar efficacy.
Heather, anything you want to add to that? And could you comment a little bit on TDXD? Of course, we talked about that earlier in our breast cancer session. Incidentally, we were talking about HER2 mutant in breast cancer, which I haven't heard much about. That's your primary thing. Again, any preference, one versus the other? Exon 14, you give it first line also. And what about TDXD?
So the exon 14, I did start a patient on tepotinib actually a couple weeks ago. I think that between the two, very similar, maybe slightly better brain activity with the tepotinib, though I think the jury's still out a little bit. I don't know if you have similar thoughts on that, Greg.
First line?
First line, though not everybody, right? In this case, it's, again, an earlier stage, potentially limited disease, so we're thinking about coming in with some radiation later to control his kind of minimal sites of disease. But I definitely had the conversation, and I think I've shifted more towards thinking about it in the first line. For the HER2 patients, I'm still using chemotherapy first line. But I do think that there's a heated discussion around that. There are certainly investigators who will think about the trastuzumab deruxtecan first line. I'm not always opposed to it. Just in my last couple of patients, there were reasons why we wanted to do the chemo, some questions about toxicity. It's a fantastic drug. I mean, response rates are over 60%. I've seen some durability of response, and it's actually been pretty well tolerated. I've been impressed with it. So to me, that's still my sort of shining example of the way an antibody drug conjugate really should work in a targeted setting.
So I'm going to ask Greg for his take on TDXD, but just getting back to the MET exon 14, and you said you don't always just use it first line. What about, would you think more about the FLAURA strategy in other mutations now that you've seen it with EGFR? Would you add chemo to exon 14 in some of these situations?
Great question. With osimertinib, you've got response rates that are significantly higher than you get with some of these other targeted agents. And so I would be more tempted to think about chemotherapy combinations where you're not going to get that single agent drug response rates of 70–80%. If you have someone with a really high disease burden, particularly like liver, would be one that I would be more worried about. I haven't done that, but it's something that I would consider in the right patient.
And Greg, getting back to TDXD, I was kind of surprised when Heather said she doesn't use the first line. We just ask people what they do, and then we plot it. And as she said, usually when we ask about HER2 mutant, we get people saying first line. We say overexpressed, they're not as excited. But I hear a lot of people say first line TDXD for HER2 mutant. What do you do?
Yeah, I typically will offer it first line, but we also, the standard clinical investigator dodge is we have a trial for that. But I typically will offer it first line.
And then, of course, the big issue, or one of the big issues with TDXD, we were just talking about that already, but of course is ILD. And I find like you guys, the lung people don't get as worried about it as the breast people, for obvious reasons, but Heather worries about it. But I am curious how you approach screening for it in addition to clinical screening, Greg. Do you use, the breast people do imaging a lot, even if there's no indication for imaging, and what it takes for you to stop TDXD in a responding patient. The breast people say, if you have any symptoms, you got to stop. I'm not so sure I've heard of that exactly from the lung people.
I think it's a lot more complicated in our space because
sure.
we're doing the scans for every single patient already. So there's lots of stuff there that we're looking at. And they're short of breath for other reasons. And so it makes it even harder. So I typically would say that I don't stop unless the patient is clearly symptomatic. And I can only blame their increased dyspnea on the drug.
And now for the star of our show, your next slide.
So we'll move on to ALK. Now, so ALK has been a dominant area of drug development over the last few years, and maybe it's more so than its frequency. It's about 4 or 5% of patients with advanced non-small cell lung cancer have ALK-positive disease. And crizotinib was the first agent approved in this space, now 12 years ago, believe it or not. And so everybody's been comparing to crizotinib. And this is, I'll show you a bunch of ALK inhibitors, and they all did the same trial. They took patients with newly diagnosed ALK-positive cancer, they randomized them to either crizotinib or this newer agent, and they did a PFS endpoint. And when you look at all those trials, you get a table like this, which is comparing response rates, 12-month PFS or PFS hazard ratio. You see that alectinib and brigatinib are clearly better than crizotinib, with hazard ratio in the PFS of 0.4-ish. But lorlatinib is even better, with a hazard ratio of 0.28. The response rates are probably similar among them. I think most of us haven't jumped into using lorlatinib as a first-line agent because of concerns around the toxicity of it, but I think there are some patients for whom I recommend this, and I think it really is the gold standard in terms of ALK inhibitors for today. So this is not new data in the metastatic setting. I think what we're more excited about is bringing this into the curative disease setting, and this is a trial called the ALINA trial, a lot like that osimertinib trial I told you about. This takes patients with resected 1B to 3A cancer and randomizes them to either alectinib or platinum-based chemotherapy. That's the big difference compared to a lot of trials. Patients got 2 years of alectinib or chemotherapy, and the primary endpoint for this trial is disease-free survival. Again, we're going to see the results of this at ESMO. Press release says it's positive, so it'll be curious to see how positive is it based on disease-free survival and how big the overall survival advantage is. Probably won't be an overall survival data presented because it's still very early. And I'll remind you that With alectinib, for patients with stage 4 disease, the median progression-free survival is 3 years. So we're going to have a hard time interpreting this data because it's going to be a very long time course for these patients on this drug.
What's got me excited is we're going to look at the data, and we've been waiting for some other, adjuvant trial that was beyond EGFR. Here it is, and and the thing I didn't realize is it's against chemo.
Yeah.
Because the ADAURA was, chemo plus or minus,
Yeah.
and if it beat chemo, right? I'd asked investigators to predict what they thought the hazard rate is, and I didn't even realize it was against chemo. They said like 0.2 and all. Of course, nobody knows, or only a few people know. And I guess, Heather, we could talk about this all day long, but the one key question is, how's this going to affect the other ones? Like RET. Every time I poll general oncologists, I say, you got a patient who's got RET, who's, a doc, and they want adjuvant RET, would you do it? And they all say yes, and investigators all say no. I'm wondering if that answer is what about the other?
So I think with ADAURA, I believe that what we're doing is when we get disease state down to minimal, and then we start the TKI, we get much longer duration of benefit. And from a simple perspective, you have fewer cells that can mutate and become resistant. So we're actually making a big impact there. I didn't necessarily think that way before kind of really looking at ADAURA. This is going to add to that, and the question's then going to be, what's the duration that we really need to continue? I think it's also important as I get into my talk about immune therapy and all the exciting data there in early stage, to help us remember that in patients with certain driver mutations, these immune therapies aren't going to work. They're not helpful, and so we do need to be having other strategies. Is this going to be enough to completely shift there? I don't know, but I think that in combination with some circulating tumor DNA and other ways to figure out, maybe there are some patients who are done and don't need, and then there are others that are probably going to need lifelong. But if it's lifelong with minimal symptoms and no symptoms of your disease, that's a win. So when you're talking about the Pelican curves, that's maybe what's going to get us there. But I'm kind of projecting out into the future a bit. So.
Yeah, ctDNA, everybody's asking how that's going to fit in. Obviously, we're going to talk about that in colon, where it's way ahead of everything else, but coming up strong with these other diseases. So really keep your eye in the adjuvant space in non-small cell. So much to talk about in the next year or two. So Heather, we want you to talk about immunotherapy and also other novel forms of treatment.
Okay, so Greg's done a fantastic job of making his slides very simple. I went with the other strategy. I've got way too much data on all of my slides, but we're going to talk about it from the simple. What are the big pictures that we're trying to think about, okay? So when we talk about early stage in immune therapy, we've got the one trial that was pure neoadjuvant pre-surgery. We've got a couple of trials now with more to come that are purely post-surgery, the adjuvant. And then we've got these perioperative, and that's the term when you're giving both pre and post, sort of like that, the whole shebang, right? So just to keep that in mind, and remember that the data results are going to be different. When we're dealing with pure adjuvant, that's disease-free survival. Disease-free because you've taken it all out with surgery. Everything else is event-free. And with the event including disease-free, but also including any events that prevented the patient from getting the definitive surgery, all right? So they're slightly different. So as you look at these hazard ratios, event and disease-free are slightly different numbers, though disease-free is part of event-free. Everybody with me on that? Okay, we're gonna start a whirlwind of data here then, okay? So this is the Checkmate 816, the pure neoadjuvant, chemo plus or minus nivolumab, a lot of stage 3 patients, some stage 1, a lot of patients with some PD-L1 expression, about half, and beautiful event-free survival. We all expect this to lead to overall survival, but we haven't seen a definitive overall survival result yet. Then we've got the pure adjuvant trial. So this is Empower 010. Again, I'm not expecting you to read this slide. You've probably seen it. You know that this was approved for patients with stage 2 and 3 disease who have PD-L1 expression based on a disease-free survival hazard ratio of 0.66. That little bar up at the top is showing PD-L1. PD-L1 levels are really important in predicting who's going to do well in every trial except one of these. So Checkmate 816, yes, it's combined chemotherapy plus immune therapy. If you dig into the data, those with high PD-L1, best outcome. When we talk about Empower 010, there are a lot who believe that all of the benefit is driven by patients with PD-L1 over 50%. A lot of controversy into 1 to 49. Don't give it in patients without PD-L1 expression. Don't give it to patients with specific driver mutations. Right, so this is our overall survival. Haven't hit statistical significance yet in the all-comers with greater than 1%. In the greater than 50%, those curves are nicely separating. Again, there's a lot of statistics. We can't say it's statistically significant, but we expect that it will be over time. All right, and then the second adjuvant trial with pembrolizumab. This trial was also positive for disease-free survival. It has not yet reached an overall survival outcome. It's completely confusing when you look at the PD-L1 levels, because every other trial with pembrolizumab, including the perioperative I'll show you in a moment, PD-L1 is really important. Higher PD-L1, more benefit. It's true in every metastatic trial. It's true in the perioperative trial. And it wasn't true here, and it still doesn't make any sense. So I think it's just, if you do enough things, statistics are statistics, and eventually you'll get a little bit of a fluke. Okay, Aegean. This is the first of the perioperative. This is durvalumab. You get 4 cycles, chemo plus or minus durvalumab. Then you get your surgery, and then you get your durvalumab or placebo. This trial was presented with very short follow-up at its initial presentation. It will be updated like everything at ESMO this year. But we see that reasonable path CR around 20% for whatever that's worth. Nice separation, a very positive event-free survival at 0.68.
Just to let you know that we're taking a real close look at this because there's going to be a breast neoadjuvant pembro study. First breast study in ER positive going to be presented at ESMO. So we're hoping that we're going to see path CR like you guys are seeing here, but we'll see.
Okay. Yeah, so this is another perioperative trial. So our same theme. This is the NeoTorch. This is toripalimab. You haven't heard of that drug yet. And this trial is different than the others because it's only the stage 3 data. It was done in Asia. It excluded patients with EGFR mutation. So that ended up being almost all squamous cell histology and mostly men because everybody else had an EGFR mutation and was excluded. So this event-free survival hazard ratio 0.4. It was somewhat PD-L1 dependent. And then the Keynote 671, this is the perioperative pembrolizumab trial. Again, this study had 4 cycles, chemo, plus or minus pembrolizumab, surgery, and then an extra year, right? So it's that extra year of treatment that defines the perioperative trials, and where I hear a lot of questions about, well, what does that add compared to Checkmate 816? We haven't clearly answered that yet, but here you've got an event-free survival hazard ratio 0.58, nicely separating. Maybe if you've got a diving pelican, you start seeing that. I don't know. Okay.
You're going to see it at ASCO next year. Everybody's going to be talking about the pelican. Was it FCS, October?
This is the overall survival as presented initially. Hadn't quite reached statistical significance. There are updates at ESMO. I will say no more. And this is specific. So now we've gone from all these perioperative trials, 3 perioperative, 1 neoadjuvant, 2 adjuvant, all positive with different drugs, very similar designs. Greg and I were talking about the fact that we really like to see more novel trials as opposed to we're going to do exactly the same study again with our drug, but you know that's where we are moving forward. But this is specific. This was our first not metastatic trial using immune therapy. So this was, of course, chemotherapy combined with radiation, followed by durvalumab. You've all seen this many, many times. This has changed practice a number of years ago. This is just showing the updated overall survival, which is looking quite promising. So this remains a standard. There's a lot of innovation happening in bringing immune therapies during radiation, a little bit of playing with fire, but that's what's being looked at. That's sort of the innovations right now, balancing the risk of pneumonitis and increased efficacy.
Before you go on, because I realize we're going through so much stuff to kind of go back, maybe it's not, at least in this module. So I want to know like what all this means, at least clinically, like what do they do? But first, I just want to comment that I remember talking to you after you first presented the Empower 010 study, and I remember you were pointing toward the Pacific trial with optimism, that you thought, you know, maybe IOs are going to be, and maybe you were actually a little bit wondering what was going to happen with ADAURA at that point. You were one of the people who were wondering. Yeah. Now we see ADAURA is coming positive. What's your take, though, in terms of adjuvant, neoadjuvant? You've got a patient who comes in with an apparently resectable cancer. their PD-1 may be not 0, whatever, 50%. Like, what did they do?
That's a great question, Neil. So I'm one of the few people who will still say that for stage 2, I think there are some patients who can go straight to surgery and get adjuvant. I think that's a reasonable strategy when there's high PD-L1, when it's a patient who just wants that surgery right now, when you are worried about potential toxicities of the systemic therapy impeding their ability to get to surgery. I can name colleagues who think I'm absolutely crazy for saying that, and they think everybody needs neoadjuvant treatment. There's a lot of biological reason as to why a neoadjuvant or perioperative is getting the drug in sooner when there's more antigen in which you're going to make your immune response. You're getting that systemic approach first, which makes sense because you've been the surveillance going. I get that.
And in melanoma, it actually works.
And in melanoma, it actually works.
They've compared it to adjuvant.
Right.
And it's better.
Right. And the stage 2 patient I saw last week, she's starting her new adjuvant treatment on Monday. So, but I think we need to be careful not to say that it's always the right thing, even though I think for many stage 2s, not everybody needs adjuvant treatment. And so if we can get our post-surgery surveillance better, such that we have ctDNA, other technologies. There are patients who are cured with surgery alone, right? There have been patients cured with stage 2, with surgery alone, going back, and it's not like the minority. It's a reasonable percentage of patients are cured with surgery alone.
And immunotherapy has its issues. Diabetes.
Do we want to have every single patient in the universe taking thyroid replacement therapy? No, right? We end up causing a lot of problems, and some of these problems are forever problems, especially those endocrinopathies. And so that's where that caution comes in. So when we're still up against most patients are going to have their cancer return and they will die, stage 3, they should get neoadjuvant because there that risk-benefit ratio makes sense. But for some stage 2s, maybe not. Do we have tests that help us figure out who's cured and who isn't after surgery? No, I don't think any of the assays, as much as they're advertised, I don't think they're good enough yet.
Talking about cell-free DNA?
Cell-free DNA is not good enough yet as commercially available. We showed that in Empower O&O and there are other analyses. But I think we will get there, and I think that's what we should aim for. I mean, our first is we push as hard as possible to get towards cure, and then we start to back off for the patients who don't need it, so we're not over-treating and causing a lot of toxicity.
So before I turn to Greg for his approach to this, just to layer in on top of what you described as kind of your approach, where does PD-1 level fit in, particularly 10 versus 95?
So as I've shown in every trial except the one outlier, higher PD-L1, more benefit, more confidence that you're really getting that help from it. I think when we deal with the concurrent chemo and immune therapy, you're getting benefit in all the patients, even with no PD-L1 expression, but where does that plot fill relative to unity? It sort of shifts closer, where that maybe you're helping and maybe you're not. I do think that we are helping, and so I am offering it, but it's a different conversation, right? And it's weighing, if this is someone who has an underlying autoimmune disease, I'm more willing to play with fire if I think that I'm really going to help their tumor. And if their PD-L1 is less than 1, then it's a different conversation, right? So it does matter, but there are other biomarkers that we need to be working on.
So Greg, maybe you can take a shot at this. I think, one of the issues here is the patient who appears to be resectable. And are you going to go ahead and give them neoadjuvant treatment at that point, which obviously is a change in paradigm? What are you doing at Memorial?
Yeah, so I think so much of this question of neoadjuvant versus adjuvant comes down to decisions not made by me, right? So it's a multidisciplinary discussion. It's which patients comes to you. Like our surgeons are very big on neoadjuvant therapy. So they're very excited about the idea of giving chemo and immunotherapy prior to the operation. And so we see a fair number of those. But I get a lot of referrals from outside of patients who have that resection and they come to me with nothing previously. And I think both approaches are totally rational, totally reasonable. And I think Heather raises a lot of points about, that patient in front of you, what's special about them? What makes it so you wonder if they're going to get through chemo easily? What things that make you wonder about what IO toxicities will affect this patient? That's sort of the stuff that all of us have to get good at.
So let's continue now with metastatic disease.
Okay, so again, you're not going to try to read these slides. They're sort of key points that I'm bringing out, and then you'll have these as references. But essentially, when we talk about these long-term outcomes, the thing to remember is there's actually about 20% of patients now making it to 5 years. Many of them off treatment. So that's really the take-home point, and we're going to show that in multiple different trials as I go through them. That's really exciting. I think we've been working together for a long time, and if I had told you 15 years ago or longer than that, we're going to get to a point where 20% of patients are living at 5 years. I think we both would have started laughing because that just seems so preposterous, and yet that's where we are, right? Working with you that long too, Greg. But, okay. All right, so these are the 5-year outcomes from Keynote-042 in patients with PD-L1 expression of at least 1%. So these are not the zeros. This is at least 1%. You can't read this, but basically what it is saying is that when we look at the 5-year overall survival and we look at the response rates, in those with a higher PD-L1 greater than 50%, it's higher than in those with just some PD-L1 expression. And the way this is set up, it's you've got the greater than 1, the greater than 20, the greater than 50. So those greater than 50s are in all of these. It's just you dilute them out with more and more people. So I think we have to keep that in mind. All right, so this is with cemiplimab. Cemiplimab is a different checkpoint inhibitor, similar design. This is in the high, greater than 50%. And I think I'll back up. You all know when we're dealing with metastatic lung cancer, there's a series of different trials. One trial series is for patients with high PD-L1 of 50% and higher, and those were giving single-agent checkpoint inhibitors versus chemo, right? That's sort of the trial design. And in the others, with a bigger variety of PD-L1 levels, those tend to be the chemo plus or minus the checkpoint inhibitor. So this is a pure checkpoint inhibitor versus pure chemo, and then you can continue the checkpoint inhibitor. And we don't have the 5-year data yet, but we've got some 3-year data looking about 40% of patients, looking like we're probably going to get to that 20% at 5 years, so another option. This is the Keynote-189. This was chemo plus or minus pembrolizumab, very practice-changing trial. Here we have 5-year outcomes. It's about 20% of patients. This was an analysis that there was a lot of criticism around because they basically said, if you made it to 2 years, how did you do? And showing that for the patients who made it to 2 years on treatment, many of them, the cancer never came back. But some of them it did, and sometimes it came back after a year, and that's a whole other question is, what do we do at the 2-year mark? We don't have time to cover all of that today, but essentially about half the patients their cancer will eventually return if you stop at 2 years. Some of them it probably would have come back anyway if you had continued. We don't know the answer to that yet. This is an area we need to question. And this is 407 squamous trial, same idea, chemo plus or minus pembrolizumab. Very similar results, about 20% at 5 years, similar analysis. Some of the patients you stop, it never comes back. Some of them you stop, it does. When you re-challenge, half the time it works, half the time it doesn't. So you got a quarter of patients potentially having a worse outcome if you stop, but a lot of questions about whether that's really a truth or not. All right, 227, bringing in CTLA-4 to your PD-1 inhibitor. Standard approach. Here we also see very similar, about 20% 5-year survivals, slightly higher when you've got higher PD-L1, but not really that different. And when you're dealing with the CTLA-4, the PD-L1 levels matter less. 9LA, chemo for 2 cycles, and then adding in the nivolumab ipilimumab. We don't have the 5-year data, but tracking to a similar outcome as well. For 3 years, it's 27%. The PD-L1 level doesn't matter as much when you're dealing with CTLA-4. Poseidon, durvalumab, tremelimumab, same themes. When you're adding the CTLA-4, you're sort of rescuing a little bit the negative PD-L1 tumors where you're getting similar benefit, these similar long-term outcomes. You're adding toxicity, though, so always remember that. All right, 5-year, we don't have 5-year, we just have the 4-year results, but tracking very similarly. So that was your whirlwind through first line. Again, high PD-L1, we're using single-agent checkpoint inhibitors. We have a lot of options. About 20% of patients are going to do really well for a long time. Chemo plus or minus, great idea when you've got a higher disease burden, if you've got lower PD-L1 expression. If you have no PD-L1 expression, I tend to believe that CTLA-4 is additive in that setting. And I think in all of these, we're getting this minority of patients, 20% plus or minus a little bit in all of these, making it to 5 years, which is pretty exciting, but it means that we still have 80% of patients we need to do better.
I'm going to take a break for a second. I got a bunch of great questions coming in from the audience.
right.
I'm going to throw out a bunch of slides we're going to show, but I've got to ask these questions. I'll maybe start with Greg. For a patient who comes out of surgery, maybe had complications, and you kind of don't want to give them chemo, because I think you use the term chemo is still, always used or something, and they don't always use it, incidentally. I'm talking about EGFR here. So what about either EGFR without chemo or checkpoint without chemo in people by the time they get post-op or maybe not in good shape for chemo?
Yeah, I've grown to be comfortable with the idea that if a patient, for whatever reason, doesn't want chemo, isn't right for chemo, that I can give adjuvant osimertinib for an EGFR mutant patient. I haven't quite gotten there for checkpoint inhibitors. I'm not sure what data I'm waiting for, but in general, I'm not using single agent checkpoint inhibitors in the adjuvant setting.
So I guess you probably don't have data on people who got chemo stopped because of toxicity, and if you had a lot of those. But bottom line is, would you use IO alone?
So every trial that I showed you, the chemo is mandated except one, which was the Keynote-091, which was that adjuvant pembrolizumab outlier trial. 15% of patients in that trial just had pembrolizumab, did not have chemo in that arm. They did terribly, right? And the reasons why they maybe didn't get chemotherapy, maybe they were earlier stage, whatever, but they really did not do well. So that's the only data we have, and it says don't do it. I think the question is still open. Obviously, if a patient gets their first cycle of chemo and they're feeling absolutely horrible, they're not recovering, I would continue with the immune therapy, but at this point, I wouldn't give it without chemo.
So, Greg, would you like to respond to Dr. Hart, who's sitting out there in the audience and is throwing questions at a mile a minute? Here we go. What do you do with the Pacific situation if they're EGFR? Because we've been asking that since Heather's put data out there, durvalumab, OC.
For EGFR mutant patients who have stage 3 disease, I give concurrent chemo RT and stop. I don't give durvalumab for 2 reasons. One is I don't think it's going to help the patient. I don't think it's going to improve their outcomes. If you look at the subset analyses, there's no clear benefit in those patients. And the second is when they recur, and we have to acknowledge that most of these patients are going to recur, giving osimertinib causes trouble in patients who are just on a checkpoint inhibitor.
And I know from asking a lot of investigators that your answer is a little outside the typical. Do you use OC or not?
I use OC sometimes. I mean, we're going to have the LAURA trial data that's going to be coming forward. We've actually published on this question, kind of pooling together with investigators, showing that the durvalumab doesn't work and is more toxic, and especially more toxic when you then have to add your EGFR TKIs, as Greg was alluding to. I don't always do it. Sometimes I give a little extra chemo. I like pemetrexed, but it's still an open question. But we'll hear about LAURA relatively soon.
Greg, back to Dr. Hart, who wants to know, you have bulky disease that's unresectable. What about using EGFR or ALK before chemoradiation to decrease the bulk?
Yeah, so this is in that range of things that maybe we do but don't talk about too much. But I certainly have done this in certain contexts, and I think it's a reasonable approach. I think when we think about what we're doing with chemo, we're trying to cytoreduce. I think we get the same cytoreduction with TKIs, even though we pretend like they don't quite kill as many cells. They're still working in the same way. So I think in certain contexts where you got big bulky disease, where radiation is going to be hard, or when you're thinking about sequential chemo followed by radiation, I'll definitely use the TKI in that context.
Heather, anything you want to add to that? And Dr. Hart's other question, which is, he's seeing a patient who had resected stage 1 6 months ago and exon 19 mutated. What about, didn't have chemo? What about starting osimertinib now? What about liquid biopsy helping make that decision?
So your first question, we're opening a trial that's looking at EGFR prior to chemoradiation. For the second question, after 6 months, I have patients with stage 1 EGFR mutated lung cancer. It's been resected 5-6 years ago that are doing okay. I've also had a couple where their brain metastases showed up at year 5. It's a tough question. I think that it's reasonable to do a ctDNA. If it's positive, you know your answer. If it's negative, you don't know what that means because they're still, again, I don't think they're quite sensitive enough. It's a question with the patient. Do you want to be taking this medication kind of indefinitely, even though I know we stopped at 3 years? I'm more of an indefinite type of person. Or do you want us to just watch you really, really closely and start it then, not knowing if those outcomes will be as good?
And I've thought already 50 times about that statement, which is you can always involve the patient if they want to be involved in these. You know, we hear over and over again, we're not sure what to do. Bring the patient in if they want to be involved.
And I think we have to remember with Adura, about half the patients never got osimertinib, the way that the study was done and where it was done. So we have to be mindful of that.
That's interesting.
Yeah.
All right, Dato-DXd.
Okay, so antibody drug conjugates. I'm only talking about one. There are a gazillion of them. So this is one of the TROP2 drugs where there will be some exciting new data coming out at ESMO. We keep advertising ESMO, don't we? But there are others, a lot of other targets, CEACAM5, this is one of the TROP2s, there are many others. These are different antibody drug conjugates than what we were talking about with the trastuzumab deruxtecan. They're not targeted in the same way. It's not like there's mutation, there's high levels, and boom, you're getting higher responses. Some of these, like this one, it doesn't matter what the levels are really. Some of the others, if there's a level there, it's a slightly higher response. So just wrap your head around that. This is like fancy chemo, but there's some exciting parts to it. So this is, again, busy. This, the datopotamab deruxtecan, TROP2 with this deruxtecan chemotherapy. So you've seen that deruxtecan in a lot of our antibody drug conjugates. I think it's one of the most potent. It seems to be really working quite well. I'm not going to go into the linker science here. This was looking at whether you can give the drug in combination with checkpoint inhibitor, pembrolizumab, with or without the addition of chemotherapy. Response rates are quite high. This is the part that I find exciting, is when you add an immune checkpoint inhibitor to this antibody drug conjugate, it's more than additive, at least at this phase, right? And we've seen a lot of really exciting phase 2 data that didn't pan out in phase 3 in the past with other drugs, but this is looking pretty good. Response rates in first line, 50% with just the 2 drugs, 57% with the 3 drugs. Again, phase 2 data, a little bit lower when you're looking at all lines, but still pretty exciting. These are the waterfall plots looking quite good. The different colors are is it a triplet or just the doublet of the antibody drug conjugate plus the immune checkpoint inhibitor, or are we adding in that platinum? And again, this is showing these response rates and some with durability of response as you would expect when you've got a checkpoint inhibitor. So what more do we know? Well, they've got some exciting first-line trials. For those with high PD-L1, it's pembrolizumab without the Dato-DXd. When you've got other levels of PD-L1, it's comparing it to the Keynote 189 regimen of chemotherapy plus or minus pembrolizumab. So I thought those are really well-designed trials. They also have a second-line trial versus docetaxel. And we've seen a press release from that it is positive. We don't know the data until we're in Madrid in a couple weeks. And this is more on that press release, so it came out showing that it was a positive trial. Remember how many trials we've done versus docetaxel that were negative, right? So this is exciting that we actually have a positive trial versus docetaxel. I don't know how positive it is. I don't know if it's going to be worth the potential additional toxicity, but it's an overall reasonably well-tolerated agent. I think there's, the ILD becomes an issue whenever we're dealing with the antibody drug conjugates, but ILD is an issue with docetaxel too. So, do you want me to keep going?
Absolutely.
All right. Last thing, tumor treatment fields. We're going to whip it around away from chemotherapy, so totally different thing. You're probably familiar with these if you treat any CNS tumors, very active there. This is using basically pulsing electricity, which changes mitotic figures in a way that I'm not going to go through in the last 30 seconds that I have, but this is a very well-established modality for primary CNS tumors. It's definitely shown some efficacy in mesothelioma. So the lung data that we saw first at ASCO and then updated at World Lung, these are patients who had had first-line chemo alone. This was an older trial. Second line was docetaxel or chemo or immune therapy, plus or minus the tumor treating fields. So a lot of criticism on the fact that this is no longer what we would do. First line, they would have already had immune therapy. But what the study showed was if you were getting single agent checkpoint inhibitor second line and you had the tumor treating fields on, you had a better overall survival. If you were getting docetaxel, it did nothing. No matter what you got, no change in response, no change in progression-free survival, just a change in overall survival. So a lot of questions remain, but I think worthy of further exploration. For the patients, there's a hassle factor, but they like the fact that it's not a systemic treatment, and they like the fact that they're an active part of the treatment. And I think that was my last slide.
So thank you first. And just a couple of follow-up questions, and then we're going to move on to GI. I was just thinking that docetaxel is like the chlorambucil of lung cancer. Everybody's trying to beat it up, and maybe after ESMO we'll have something else. But I'm just kind of curious of Greg's take. First, we were talking about data before at the breast people because they're looking at that at ESMO also. You guys have much more experience with it. We hear about mucositis. Any experience in terms of tolerability with Dato?
Yeah, so I think that this is going to be interesting to understand the toxicities of all these agents and what's the toxicity related to the antibody end, what's toxicity related to the chemo end of all this. And it does appear that mucositis is sort of a unique component of the Dato-DXd profile. We don't see that with PAT DXd, and we don't see that with the other DXd, so it's a little bit unique, so it must be related to the antibody. I think it's generally manageable, and I think we can all agree that we've learned how to manage the docetaxel toxicities, which are real, and we'll probably learn how to manage these.
Mm-hmm.
So you guys know about the Pelican? I'm asking the GI, but you know about the Pelican plot? Never heard of the Pelican? Oh, you can hear about that in a second. Anyhow. So final thought about tumor treating fields. Curious, Heather, what your thoughts were about data survival benefit. You know, maybe there's some other explanation, but at least it's a different form of therapy. Any thoughts about where this might head? If it does turn out that somehow it's synergizing with IO, does that make any sense?
It does. I think it could be real. Again, it was a phase 3 trial, but when you break it down to just those who got IO, it wasn't really a phase 3 big one. So I think that what they're doing is moving it into first line in combination with chemo or IO alone. And I would certainly encourage patients to enroll in the trial. Wouldn't recommend this yet, but I think it's definitely worth further exploration.
Yeah, that's, I think, the key issue. All right, thanks so much. We're going to move on. Thank you.